Network. And we have a great presentation on tap today. And we've got Jennifer Rayman and Wendy Elmo here from Brain Links. You might recall we had them on here a couple of months ago, had Brain Links on here a couple of months ago. I don't know if it was a couple of months. How long ago was that? Maybe about a month ago. In any case, we're going to have them back as a regular guest now because they've got lots of different pieces of information to provide to us. And so we're going to have them back to do a series of these. And so I'm very happy to have today Jennifer Raymond and Wendy Elmo to talk to us today. Jennifer, we were talking a little bit about television shows here a little bit earlier. I'm trying to remember, you had told me an interesting fact about yourself that I'm not 100% recalling right now. Maybe you can tell me that. And if you have an additional one that you can add to that, that would be great too. But also just introduce yourself as it relates to Brain Links and everything that you're doing.
Sure. I'm Jennifer Rayman, and I'm in East Tennessee with Brain Links. I'm happy to be here to talk with you today. I'm going to be the only person presenting with Brain Links today, but we're lucky that we have kind of a series going on with you guys with these calls. So you'll be hearing again from Wendy soon, and we have probably the whole Brain Links team joining the call. An interesting thing about me, I think you're thinking from a minute ago, we were talking about Karate Kid because of that new show coming on Netflix. Oh, yeah. And
you already revealed you had a big crush on Ralph Macchio. It's Macchio, right? Yeah. I always want to say Macchio.
Yep. I had his poster on my wall for years. Loved him. So one of my first big movies that I remember watching besides Footloose, those were just two powerful movies in my childhood. So he was important.
Did you have Kevin Bacon on one wall and Ralph Macchio on the other?
I liked Kevin Bacon, but I don't know. I don't think that I had him. I think I liked Michael J. Fox and let's see. Who is it in The Outsider, Michelle? Who is that? Justin Bateman.
Justin Bateman.
Yeah. So those were my
Dodge. For me, his best thing was Dodgeball.
Oh.
Where he played opposite Cotton McKnight. They were the announcers for the Dodgeball tournament. He was excellent in that. But I digress. I'm getting into my kind of mode where I am just soul movie buff. I just start waxing about all these different movies I've seen. But that's not what we're here to do today. We're here to talk about Brain Links and concussions. And so you've got a presentation here for us, and I will.
I do.
I'll let you get going with that, and I'm sure I'll have some questions along the way as you're going. So I'll just jump in. Anybody who has any other questions can also put them in the chat box or jump in and take the opportunity to unmute yourself and discuss this topic with us. So I'll leave it. I'll turn it over to you at this point, Jennifer.
Thank you, Dr. Davis. Michelle, have I got this up right where you guys are seeing first slide on the PowerPoint?
Yes, ma'am.
Thank you. Okay. Well, we are really happy to be here and talk about concussion and mild traumatic brain injury. I'll tell you a little bit about our program as we go. I thought I would share just for a moment about what got me into brain injury. I was a high school student. I've already kind of dated myself from that era for those of you who watch those shows we were talking about. But I, shortly after high school, worked a work-study job at a rehabilitation hospital, and I was lucky enough to get a chance to do that and get some hands-on experience observing and sort of assisting with people that worked with people in rehab, and there were just a handful of people there at the time that had brain injury. And because I was so young, I really related to them. They were 11 and 18 maybe, and then a 40-year-old. And I still remember them so well, and I just knew then that that was something that really appealed to me, and I wanted to work in this field somehow. So that led me down a path in school to go into working with people with disabilities, and then eventually onto the job that I got with this program that used to be called Project Brain, and then with our most recent grant, we are now Brain Links. But essentially, we've always been providing training to people regarding brain injury.
Well, this is really important stuff, though, because we, I think, and a lot of times clinicians who work in the field of ID are often just, not really that they may not think enough about the neurological effects of the person's disability, and kind of just taking it, well, okay, this is the structural situation that we have with this person, and kind of taking that for granted. But the more we can understand about these matters, I think the better ideas about treatment, the better ideas about how to teach somebody something, the better we can do with all of these different interventions that we do. So this is just critical stuff that we learn from you in these presentations.
Thank you. Thank you. I think that we came together because although we're talking about concussion, traumatic brain injury, and somebody being hurt, it can also apply to anyone with cognitive changes and with cognitive challenges. So just knowing this information about how the brain works and how someone thinks, it might, let's see if I can.
Yeah, people with a TBI who had that TBI prior to age 18 might be someone who would be identified in our system, number one. But number two, even if they didn't, there are still structural differences that we need to understand and to be able to have an impact on that person. And as you're talking about concussions, we have a fair number of people who have regular concussions. I mean, so in other words, engage in some kind of self-injurious behavior that may result in kind of a repeated scenario there, and we're not often thinking about the impact of this. So this is just, I think, very timely and critical.
Thank you. Well, I'll tell you just a minute here about our grant. We're funded through a federal grant with the Administration for Community Living, and it's also in partnership with the Tennessee Traumatic Brain Injury Program. That partnership has been going on for the past 20 years in Tennessee. Are these, is there a way that I can shrink these so that they're not in the way? I don't want to obstruct anybody's view.
You should just be able to close them.
Okay. There. That's better. And does mine need to stay up here?
Yeah, that's fine.
Okay. Oh, got it. Okay. So with Brain Links, we are a statewide team. There are 4 of us across the state of Tennessee. I'm here in East Tennessee. I work out of Knoxville, but cover all of East. And then we have in Middle Tennessee, Wendy, who you maybe heard talk before on a previous CCN call. And then Paula, our director. And then we have Carrie in West Tennessee. And we equip professionals to better serve people with traumatic brain injury using current research-based training and tools. And one thing that I like best about us is that we really work hard to make sure that we have family-friendly materials. We have made sure that our materials are usually at a 6th grade reading level. We have resources for returning to school, work, and to care. And that's something newer with Brain Links that we cover working with adults and adults with intellectual and developmental disabilities. We have toolkits for healthcare providers and for school nurses, and we've recently added a YouTube training channel playlist just for DID. So I wanted to ask people in the group just for a moment, you can answer this as you have time in the next few minutes, but I would love to know from such a large group joining this call where you're at in Tennessee. So if you take a second to just tell us maybe your county that you're in and what role you work in, I just would love to be able to hear that feedback.
You want them to enter that in the chat, or are you wanting them to come on and tell you that? It'd probably be more efficient if they told you in the chat, but.
Yeah, in the chat would be great. And maybe Michelle, in a minute, if you could just let me know some of those answers. It doesn't have to be everybody, but we would love to get to hear that feedback. It's nice to be able to reach so many people across the state in different roles. You guys have a really diverse group in this meeting.
So far, we've got everything from Greene County to Davidson County, Memphis, Shelby County, Washington County, Jonesboro, people from DIDD, TEIS, Knox County, Hardeman County, behavior analysts, Greene County, more Shelby, Wilson Therapy Services, Jefferson County. I'm pretty sure we're covering the gamut of counties at this point.
I saw Julie Hurd came from Carroll County.
Yep, we've got Gibson County with RHA, Williamson and ISC's on, Rutherford County, Murfreesboro, Carroll County, Washington County, Hamilton County case manager with Katie Beckett, Anderson County. Covering them all.
Cool.
Widespread.
I appreciate that. That's just really neat to know how many people are on there. And with our program, you can connect with any of us, and we'll get you in touch with the right person. But the three of us doing training in each of our regions of Tennessee, it's nice. I think it's nice to know, people are on from our area. So what we're going to talk about today is an overview of concussion and mild TBI. We're going to talk a little bit about an active treatment model and physician's concussion protocol. Both of those are going to be something maybe a little bit newer to some of you as far as thinking about concussion and treatment for concussion. We're going to talk about how to identify symptoms, and we have some awesome tools and resources for you. Probably many of you that joined today either know someone personally or work with someone who's had a concussion or a traumatic brain injury, and I hope that this is something that's helpful to you and gives you ideas of ways to maybe provide more help and more resources for them. So what is TBI? A traumatic brain injury is caused by a bump, blow, or jolt to the head or body, or a penetrating head injury that disrupts normal function of the brain. And the important part here to think about is that your head doesn't have to hit something to have a traumatic brain injury. A concussion or TBI can be caused just by a jolt to the body. TBI can happen when you're least expecting it. So maybe we think about people getting a brain injury or having a concussion when they're doing something dangerous. It can actually be more common in playing sports, a daily activity like stepping down from a high step or falling downstairs, maybe being in a car accident and having whiplash from what seems like a minor kind of accident or a slow speed like a fender bender. With those types of injuries, people can really still get hurt seriously and have lasting symptoms. Falls are most common among the oldest and the youngest, but then you also have injuries that can occur from, especially in Tennessee, ATVs. And there are also injuries that could be prevented, like being shaken violently or domestic violence and people harming themselves. One thing about concussion that maybe people don't automatically think about is that it's not going to show up on a CT scan. So if you go to the hospital, you're seen for concussion, one of the first things you might think is you're going to get a CAT scan or CT scan, and that it's going to tell you the results, if you're okay or not. And with a concussion, you're also not going to have that CT scan because they're not routinely doing those images for concussion. And even if you do have a scan and it's clear, it doesn't mean that you didn't have a concussion. And part of the reason for that is that concussion is more considered a functional injury as opposed to a structural injury. So think about with functional injury that it's more of a change in the function and the abilities that you have, where with structural, that would be more of a change physically in the brain. So structural injury you can see on a CT scan, functional you see in how the person interacts or behaves or performs. And the chemical cascade that happens with concussion can, just to very simply describe it, it's when different chemicals that are in your brain at a cellular level, that's going to be calcium, for example, when there's an injury that causes breaking or tearing of the axons that send messages in your brain, calcium will rush out of parts of the brain where it belongs into parts where it doesn't. And when that chemical cascade happens and that change happens within the brain chemically, that's when you have those concussion symptoms. One of the things that we wanted you to know about is a new method of treatment following concussion. And the University of Pittsburgh Medical Center has developed this new method for treating concussion very different than we have in the past. So instead of treating all concussions the same with rest and with time, they focused on the person's individual symptoms and an active treatment plan to begin addressing those symptoms. So in the early days of concussion, the symptoms are broad and generalized, and especially that first week or so, they might include things like headache or fatigue. But after the first week, if the symptoms persist, they tend to fall out into one of these categories or trajectories of concussion. We simplify it and say in the 6 types of concussion, but they might have problems with vision, with cognition, fatigue. They might have post-traumatic headache, migraine. That especially might happen for people who already had migraines prior to the injury. They might have cervical or neck pain, changes in mood or anxiety, and then trouble with balance, with vestibular changes. What's different about this type of treatment?
So Jennifer, let me ask you a question about that previous slide, if you don't mind. So on this one, so you were talking about a structural versus a functional injury. And it looks like all of these things probably could result from either type, either if you had a structural physical insult to the brain, you might have some of these different types of symptoms, or if you had a functional injury, it might affect you in one of these different areas. But correct me if I'm mistaken in how I'm understanding that.
I think that that's fair to say. Yeah. However someone is injured, if it's an injury to the brain, I feel like they can have trouble in any of these areas. What might be a little different about concussion is that it's usually a milder injury, and it's often going to be that they recover quickly. But there are some people with concussion who are going to have symptoms longer than you'd expect, and it would be more like as opposed to concussion being thought of as a mild traumatic brain injury, those symptoms might be more like a moderate injury.
Mm-hmm. Okay.
So yeah, anything that's involving the brain can involve one of these areas, including concussion, which people usually refer to as being pretty mild. What's different about this type of treatment is that instead of waiting for the person to rest and get better, which that's still recommended, 2 or 3 days of good rest is still very important. But instead of rest and wait to see what happens, it's about getting treatment quickly and targeting that treatment to the symptoms that they're having. So if they fall into these types of symptoms that maybe are cognitive fatigue and mood and anxiety, you're going to get somebody to that type of specialist quickly. They're going to maybe need medication, maybe see a psychotherapist. Cognitive behavioral therapy is what's the CBT with mood and anxiety. But seeing that they're having those troubles and getting them to a specialist who works in that area, really just in the first few weeks following the injury, has been proven and researched to show that it helps people recover better and more quickly. Some of the symptoms that you're looking at here go into a little bit more detail there as far as things that will follow concussion. So they might have sleep disturbance, fatigue, be really sensitive to lighter sounds, especially things that you might be able to see, or changes in behavior, crying easily, very irritable, quick to anger. Everything that you do, everything you think, learn, remember, every part of your life is controlled by your brain. So the list of possible symptoms is just huge. And headache and fatigue, for example, aren't really easy to observe. But if you think about how you felt before when you've been maybe at some point really sleep deprived in your life, what that feels like to try to interact with other people, be responsible for doing things, to complete a task. It kind of gives you an idea of what that's like for somebody who's had a concussion. I wanted to include some slides in here for people that work with younger children, since early intervention is now joining BID, and I'm hoping this will be helpful for some of you. And for those who don't work with early intervention, I bet you have children or grandchildren that this might be helpful to know. But for the youngest kids, it can be a little harder to notice those symptoms. Some of the things that you might look for would be changes in appetite, changes in sleep, stomach aches. But there was a study in 2018, that was the Subscour study that's mentioned there, that focused on younger children's concussion symptoms. And what they found was that it was pretty common for younger kids. There was a significant finding to have trouble with decreased engagement following concussion. And not just decreased engagement, where maybe there was a period of time at the time of the injury where they kind of relaxed and didn't do as much, weren't as active. Maybe you think of them just sitting on the couch watching TV, or not being themselves. But then following that, there was a change in behavior. So with that behavioral dysregulation, they found more tantrums, more fighting, more crying, more difficult behavior. And what this pointed out was that in the younger child, it may take a little longer for those symptoms and changes to show up, but it's very important to still relate those back to the concussion, because they are likely part of the recovery of that concussion.
There was an interesting question down here from Jennifer Terranera. And she is asking, is it possible for someone to experience these symptoms 8 years after a TBI? So a longer period of time. So I assume she's asking, would the person not have shown any symptoms, then show them 8 years later? I'm not sure if that's exactly what she's asking, but it seems that way.
Excuse me, Bruce, this is Jennifer Terranera.
Yeah,
I wasn't sure if I could just chime right in. I didn't want to interrupt
please do.
our presenter. Yes, this is more of a personal question, but I'm also on here, of course, for all the young children on my caseload.
Yeah.
I experienced a TBI. I had a traumatic boating accident out on Wachata Lake. I'm not sure exactly what happened. It was so quick. And Jennifer, I love the brain, and I'm not sure if it was a coup contre coup injury that I suffered, but I ended up in the emergency room, was looked at by some professionals and patched up, and went back to work after that weekend. And I've been suffering from a lot of these symptoms, so this is personally interesting to me. And I'm just wondering if it's quite possible 8 years after an accident to be feeling and experiencing some symptoms that you just described on that previous slide.
Yeah, I think that is possible. And when someone's had an injury to their brain, it can change and affect new learning from that point forward. One of the most important things, I think, is to suggest, for one thing, because we're not medical professionals with brain links, although we have learned quite a bit about brain injury over the years to be able to do our training. one of the things we'd recommend is to go back to your primary care physician and talk with them about symptoms. We'll show some things that you can use as resources later in the presentation, but probably the most important thing to keep in mind is that it's never too late to go back and do some therapy or to work on those symptoms and to make improvements.
Thank you. I appreciate your response.
Sure, sure. So just for a moment here, we'll touch back on the very young. Some symptoms to look for in the very young might be a little harder to see than in an adult who can tell you what's going on and what they're experiencing. They might do things like hold their head, might be more clingy or maybe more withdrawn, not eating the same way. And these behaviors are important to point out because these also might apply to someone who's older, an adult, who communicates without using words. So you can look for those changes in someone that you care for that might not be able to explain exactly what's going on.
So the touching or holding of the head in particular, so this is the person are you presuming the person's experiencing pain at that point? I have a particular reason for asking, but is that what you presume is the case? They're having a headache perhaps, or is there some other draw to touching of the head in that circumstance?
That's a good question. I mean, my first guess would be that they're having some kind of pain and they're holding their head from pain. Right. But I think it's also a possibility that they could hold their head from overstimulation with noise or with lights, or it might be a way to comfort.
Yeah.
So I first would think pain, but I think it actually could mean more things. And it might be a behavior.
It really is, and I like the direction you're moving with it, because a lot of times looking at these more subtle types of things that people are doing first, a lot of times we're looking at behavior problems, that people may have, and we're thinking about it in this way. Okay, it's aggression, or it's self-harm or whatever. But these smaller things that you might notice about someone can give you a lot more clues, perhaps, as to what's going on with them. And that idea that someone is having headache, maybe experiencing sensory concerns under that circumstance, I think would be really important things to consider.
And these are some pain indicators, and these are, again, especially written for the very young, excessive crying, muscle tightness, facial changes, changes in breathing, something that you can look for as a sign that someone's in pain, but these also will apply to adults as well. And because I mentioned ways that people are injured through abuse, I just wanted to point this out. We did a great session for DCS recently and included this slide, and I think it's an important thing to talk about for just a minute, the 10-4 bruising rule. I'm not sure if anybody on here has heard of that before, but essentially it's 10 is torso, ears, and neck, and the 4 is in children 4 years or younger. So if you see bruising in those areas, an infant should never have bruises, and a child this young, 4 years or younger, shouldn't have bruising in these areas. So that's a cause for concern that there's possible abuse going on. Danger signs just to look for in anyone of any age regarding a head injury would include having a pupil larger than the other, being really drowsy or hard to wake them up, slurred speech, definitely loss of consciousness, repeated vomiting or nausea or seizures. Those are emergency, let's get help right away problems. And concussion in older adults. So we've talked about younger children. We've talked about all ages, but for older people, concussion can be a little bit more easy to to have. They're more susceptible to concussion. So that even a fall to the knees could cause a concussion for an older adult. They definitely don't have to hit their head. No one has to make that contact for their head to hit something. But just for an example, bumping heads with their grandchild. It doesn't sound like a big injury, and the grandchild might be fine, but that kind of injury could actually cause a concussion for an older person. The signs can be more delayed in older people because they have a larger intracranial space that comes along with aging, and also things like medication can come into play. So it's less likely to be diagnosed and treated, but concussion in older adults is a serious injury, and they still need to be seen just like anyone else. So you don't have to hit your head against something to have an injury. A clear CT scan doesn't mean that you don't have a concussion, and there is no such thing as having just a concussion or only a concussion. You can have long-term consequences and long-term symptoms from what seems like a minor injury. If it's an injury to your brain, it's potentially very serious. Well, we talked a few minutes ago about the 6 types of concussion, and now I want you to think about going to the doctor for that first visit to the primary care physician after a concussion. We are asking healthcare providers to always look at concussion as a 2-visit diagnosis. In our toolkit for healthcare providers that we mentioned there at the beginning, this is kind of our shining star of the toolkit. The whole point is that a patient starts with the 2 visits, they get seen, and they're given the information to take home and look for new symptoms, or if symptoms continue. If the symptoms continue, they go back 4 weeks later, and then they might need to be referred to a specialist, just like we were talking about a few minutes ago, depending on their symptoms, someone who would see, they could see for those individual symptoms they're experiencing. And then if they don't have symptoms, then they don't need to go back. They can cancel that next appointment. And this is something to bring up every year and continue to talk about concussion, at least bring it up, especially if there are lasting symptoms or new symptoms. What we really want to do is think about concussion not as a single event, as a one-time thing that happens, but a process. So there's the injury, so there's the impact, the initial impact, there's the injury that occurs as a result of that impact. Then you have the symptoms and a recovery, and some people's recovery might last only days, and some people are going to have symptoms months and even longer down the road. There's really no set time for recovery, and sometimes people can feel really frustrated with their symptoms and even feel like maybe that they're failing in some way for not recovering as quickly as other people do. We work with individuals sometimes who ask us for information and ask us for resources, and that's not uncommon. So if you know someone who's had a concussion or a TBI and they're still having symptoms, this is a good chance to get some information to get them help. And
So,
there's no shame.
question here about a concussion, Jennifer. Is it suspected that you're generally going to recover at some point when you have a concussion? So different from, or as a subset of traumatic brain injury, where, you know, it seems to me there's been some structural change that it'd be more likely that this might become a permanent change for a person. But I'm just interested in how you would respond to that.
Yeah, so I would think of it that a concussion is definitely a milder form of traumatic brain injury. All concussions are traumatic brain injuries. A concussion is much more likely to be something that a person recovers from quickly, maybe in 2 or 3 weeks, but there are people who are going to have longer lasting symptoms. So it's a smaller percentage of people with concussion, and it's interesting because it seems like if you had a milder injury, you'll have milder symptoms and you'll get better quicker. Overall, that might be the case, but you can also have a more moderate to severe injury and have almost all of your symptoms heal as well. So It's possible to have a milder injury like concussion and have a long-term recovery and have symptoms go on. And it's also possible to have a more severe injury and heal quicker than you expect. The higher percentage is going to be that people with concussion heal in a couple of weeks and totally get better, but some don't. And people with a more severe injury have a longer recovery and may not go back to 100%.
Thank you for that.
Sure. Yeah, it kind of makes sense the way that works, but it also it's important to note that not everybody heals the same way, and not everyone has the same supports. And the brain is just such a very intricate and complex organ that is in charge of every aspect of your life that it just no two injuries are the same. So now we're looking at the nurses' concussion screening tool. We have permission from the CDC to modify their concussion screening checklist for school nurses to make this and to better fit people with more medical needs. So it describes the injury on here, and it has the directions down the side. It gives a quick signs and symptoms checklist that they can check at 0 minutes, 15 minutes, 30 minutes just after the injury, and along with the next steps, when you might need to seek medical attention, and danger signs and more details are on the back. So here's what the back looks like. This might give you a place to put if they had a loss of consciousness, even if it was just for a few seconds, and to list any other important symptoms that you're noticing here. If the person's not able to participate in treatment with a therapist in the usual way, they really should still be evaluated, because some symptoms can be really debilitating, like changes in balance or vision. And this is where there's a chance for the caregiver to be flexible in being able to help that person with doing some of the therapies at home and working more with them individually. I wanted to point out stroke here just for a moment, because if you're not familiar with stroke and you didn't see the person get hurt to know that they've hurt their head, you might notice some of these symptoms, and it's really easy to remember because it's fast. Face drooping, arm weakness, speech difficulty, and time to call 911. So looking for these changes in someone who's injured and you're not quite sure what happened just takes a moment. But the quicker they get help, the better chance they have for recovery. And then stroke symptoms are really different for women. Pretty much all of the symptoms listed for men, face drooping, arm weakness, speech changes, are the same for men and women, but especially for women, it can include less obvious symptoms like general weakness, disorientation or confusion, fatigue, nausea, and vomiting. So I had a case here. I just wanted us to think for a minute about an example of what you would do and what you need to know. So Millie, you've entered the house and you find her on the floor next to her bed. She's conscious and she's alert, but Millie is somebody who does not use words to communicate. She's nonverbal. And she's trying to sit up, and you're worried that she may have hit her head. And what would you do? It's a good chance to think, do you have a protocol for this, and how would you react? If somebody wants to type into the chat or take a moment to speak up, this is a chance for us to talk for a minute.
This is Jennifer. I'm usually not shy in these types of situations, even though I do not work with older people. I think if she is nonverbal, I would probably try to find a way that she has been communicating either with caregivers or loved ones. I might use pictures, any other form of communication that I could think of, just thinking outside the box, maybe I don't know, trying to point to the just something to get her to tell me maybe what happened to her. And then I'm not sure. I haven't done my any kind of updated training yet for emergency situations, but maybe try to assess pupil dilation, looking at her eyes, um, just going by the stroke protocol that you just kind of talked about, especially for women and an older woman. Um, I'm not sure. Definitely get 911 kind of pulled up on the phone after seeing how she is, and maybe just taking it from there.
I liked your answer, Jennifer. I really appreciate that. You know, what I loved about it is that you didn't say get her up and help her sit up. And I think some of the things that we've learned about helping somebody is that you just don't know what's happened until you walked into the room. She may have been laying there a long time. She might have a broken bone. This may be completely related to blood sugar or blood pressure. So having a plan in place for things like this is important, and being able to, where you want to hurry when you know that someone's having a stroke, to get them help right away. You don't have to rush so much that you don't take a moment to assess the situation and to know how to help them best. So where it might make people feel more comfortable to sit somebody upright quickly, Millie might need you to just be patient and be there for her. So thank you.
Would you, so what, under what circumstances in a situation, because somebody said here, call 911. I just wonder what your reaction to how quickly should you try to attain those emergency services for someone in a circumstance like this? Should that be one of your first steps?
I'm not a medical professional, so I will defer to someone in the group who might be for an exact answer. But I'll tell you my decision that I would make if this were my mom, I wouldn't spend more than 90 seconds.
Okay.
I would be looking at her eyes. I would be trying to communicate in the way that I know how to with this person. We're assuming it's someone that you know well, either personally or with work, and seeing if I can get them comfortable, and I would have my hands on the phone while I'm doing all that. And I would be calling 911 quickly.
And your expectation would be that you're able to, so she doesn't communicate with words, but whatever method of communication she does use, that you would be in a position to try to establish that communication with them and verify that they're able to communicate with you in that way. Am I understanding correctly?
Yeah, you would be looking for them to tell you if they've hurt themselves, if they fell, if they hit their head. Here's some good answers coming in. Ask them to perform a simple task. You would be able to communicate with them in the way that you normally do, and if you see changes that are worrisome, like some of the symptoms that we've talked about for TBI or for stroke, I would call 911.
Great, thank you.
The most important thing, sure, is having that protocol in place so that you kind of have a checklist that you would go through for that person in advance. And then know that that's the procedure everybody agrees on if they're the person to find someone in that position. Yes, and if you have a falls protocol, definitely defer to that plan. We're going to look here again at another tool that we have developed from the one that was already existing for the CDC. This is our return to program letter, and the CDC had already created a return to school letter that was more for children who were returning to school after a concussion, and we just redesigned this for return to home, community-based, and residential services. So it's got the person's name, date, the healthcare provider, and then a great checklist for the doctor to easily check a box for symptoms and suggestions. And this is our symptom tracker. So the symptom tracker is so easy. It's just one page. It's a great tool for addressing one symptom or maybe a couple, and it gives you a chance to look really carefully at what might be the contributing factors. So it's something that you can take back to the doctor and show them not just what symptoms you're having, but when they happen, where they happen, and what you did to try and help it, and did that help? when you start to get this data together and share it with your doctor, you can really be actively working towards a solution for your symptoms. So how do you determine if a concussion or TBI exists when the child or the adult already has another issue? For instance, it might be somebody with ADHD or with autism. How are you going to be able to figure that out?
Yeah, and Jennifer, I think intellectual disability in general, you know, there are a lot of times it's sort of like it gets mixed in with other difficulties that the person may have. And so those other difficulties, the difficulties associated with intellectual disability sort of overshadow what may have occurred with a traumatic brain injury of some kind. And that term diagnostic overshadowing, actually intellectual disability, it overshadows sometimes a lot of different things that may be going on with somebody that you really need to be noticing. And so this would just be another example of that.
Well, one thing that you can do is think about their history. So if they had an injury, did they have signs of TBI? Has that person ever fallen off from the bed or fallen down the stairs? Were they ever in a bicycle or car accident? And the symptoms that you would be looking for are like these listed here on the right. They might be headaches, fatigue, anger, crying without being able to be consoled. You would go back to your signs and symptoms tool. So at that time, did you see any injury, any bruising? It might have been a concussion. And it might be, let me go back up there. Whoops. And it's also thinking about worsening of their pre-existing behaviors. So they always had maybe a problem with staying on task, or they always had issues with balance, but now those things are worse. So maybe before they could focus for an hour, but now they need breaks more frequently. They're falling more frequently. They're having more behavioral outbursts. So maybe what you've already been doing to help with these things will still help, but it might take another type of therapy, like vestibular therapy for balance or ocular motor therapy for vision. We looked just a minute ago with the signs and symptoms tools for children. It's that one on the left. We also have one just for the youngest children up to age 5 here on the right. And we also have a signs and symptoms tool for people who communicate without words. And you can see here we have a little enlarged section here for signs of pain and what symptoms might look like. We like that we have this available for all ages, from the 0 to 5 all the way to adults and older adults. This is our signs and symptoms tool for adults, and we even have this section here for changes that would be specific to older adults. And now we're looking at our when concussion symptoms aren't going away. You know, when I said that we love our family-friendly materials, this is one of them. Probably one of our nicest and most comprehensive tools is the when concussion symptoms aren't going away. You're looking at the one for children 5 and under here on the left, and that will include early intervention services as a resource, and the one for school-age children here on our right. And essentially, these tools follow the child immediately following the injury, and then weeks, months, and even years down the road. We have the same thing available for adults. And then this is going to also include for adults going back to work. So there's going to be great resources nationally and in Tennessee. Here's a little closer look at some of the things that are included in those tools that we were just looking at. And these would be important for you to take those tools. The When Concussion Symptoms Aren't Going Away is a 4-page fold-out, so it really is comprehensive. But to circle those changes that you're experiencing and take that back and share it with the doctor. So that could be changes with vision issues, changes in personality, just not feeling like yourself, short-term memory problems. All of these are associated with concussion and TBI. It's more of a change in the way that we think about concussion and the way that we think about serving people, and asking not what happened asking not what is wrong with this person, but what happened to them. And if you have that history and you know more about concussion and TBI, you can begin to make this connection and understand that maybe this injury has caused more changes than you realize. Look for changes in behavior, be really patient and consistent with them, make sure they don't get injured again. If you see any problems, you really need to make sure that the doctor knows what's going on. The doctor can complete that return to program letter and share it with the appropriate people. Maybe that's the ISC, maybe that's the conservator, or the people that are spending the most time with that person. For some people, they might need to see a physical therapist or occupational therapist or a counselor. Those referrals can be really important, and if you know that someone needs that extra help, it's okay for you to be the one to step in and suggest it. All of these issues can contribute to problems down the road. And with traumatic brain injury, there have been studies that have shown that people with TBI are more likely to have another injury, to become obese, to abuse substances, be socially isolated. In our future talks for CCN, we're going to talk about how to take care of your brain, and you'll get to hear Wendy talk about brain health. And I hope that you'll join us for those, because it's not just helpful for people with brain injury who are needing to take the best care of your brain, but really everybody. Always look at changes in behavior, of unwanted behavior, as a way of communicating what's going on. To break it down and take something like that, not take it personally, can be kind of hard, but look at the situation where there are cognitive demands on the person that were just too hard for them to deal with. Did they have the words to be able to explain what was going on? It might just be that they were really frustrated. So look for a way to calm things down and get their input on how to practice or model different behavior when things are a little calmer. And I think I'm not going to have time to talk about Doug here. We're getting too close on our time. But I just want to point out the importance of being able to communicate with the circle. So everybody who's involved in working with people after a concussion or brain injury needs to know what's going on with the person, the symptoms they're having, the basic protocols in place if they need some help, and for knowing resources that can be helpful to the people working with that person and to the individual, especially when they're in part of a big circle. They're going to need supports with every transition, whether it's a new job, a new school, a new home, a new doctor. If someone is working, the Job Accommodation Network is a great place to go for resources for accommodations, including those for brain injury and stroke. The Service Coordination Program is with the Tennessee Department of Health Traumatic Brain Injury Program, the best friend to have if you've ever had a brain injury and know someone who's had a TBI. They can help them in a sort of a case management role, and this program is a free service and it's unlimited time-wise. And here's what's going to be coming up with us. We're going to be joining you guys again in November and in January to talk about cognition and brain health. And there's a look at all of us. I'm Jennifer over there on the right, and this is your group with BrainLinks. We might have a minute for questions.
Jennifer, this is Jennifer again. I have a question about the young ones that I work with. For 20 years, I've been working with our Hispanic community here in East Tennessee. I'm out of Washington County. There is a great migrant stream that comes through, and I love working with this population. Has there been anything in regard to, and I don't like this term, but the Mongolian spots that are pretty typical on newborns of Latino, Latinx, Hispanic ethnicity, origin? They look like bruises. And oftentimes I have had some of my families go to doctor's appointments. Their children are enrolled in early Head Start programs, and some of the teachers notice these spots on a child and think they are bruises when in reality they're not. They're common for this child to have these darker spots on their body. Is there anything that you guys have noticed? Are you addressing this?
Wow. I am not familiar with it. I appreciate you having that question because it's something I'd like to look into a little bit more. But no, I'm sorry, I don't have any experience in that. Maybe if there's anybody else on the call that can answer or has any idea, I'd appreciate it.
I think these are I'm not sure what the cause of those are, but they're just part of the person's natural color, essentially, and their presentation, and not caused by abuse necessarily, as is probably suspected in a lot of circumstances. I'm not sure, Jennifer, if you were saying that there was some neurological connection with that or not.
No, sir, not necessarily neurological. I guess I was going back a few slides, and in Jennifer's presentation, I had noticed, especially, was it the 410s you had popped up on your screen? I'm sorry?
The 410 bruising rule?
Yes.
Gotcha. So it could be possible for people to mistake those for abuse.
Right.
Yes. So that just hits home with me working with this lovely group of people. They're near and dear to my heart. I feel very fortunate that I'm able to help out our Hispanic population in this area, in the First Tennessee District, and really just want to help them even more.
Thanks for sharing
that's
that.
great.
I didn't know that.
Well, Jennifer, I want to thank you so much for coming on and joining us today and telling us more about this. I think it's very educational every time that we come together to hear these things and to ponder them a little bit more and to think about how they may affect some of the folks that we serve in our different systems through DIDD and other systems that may be tuning in here. So that's really great. Thank you so much for being here.
My pleasure. Thank you all for what you do. It's a pleasure joining up with you all.
And let's not forget, you are coming back on November 17th and 24th, and then again on January 12th and 19th. Got a lot of great topics coming up, and I know these things are going to stimulate a lot of thinking for our audience. So I really appreciate your committing to doing this series of presentations here, and everybody at BrainLinks for your participation and assistance with all of this. So we do this every Tuesday at 12:30, the Clinical Consultation Network. Please join us again next week for another exciting, we're calling them episodes now sometimes. So I guess these are kind of like episodes of Cobra Kai. These are our episodes of clinical consultation. So appreciate everybody being here. Be with us again next week. And again, thank you, Jennifer.
Thank you. Bye-bye.
Bye-bye, everybody.